Hey everyone, welcome back to Medfoxes. In this Cardiac Pacemakers, a beginner's guide series, we are moving on to an important topic: hemodynamics of device therapy. Understanding how pacemakers and other cardiac devices impact heart function is crucial for optimizing patient outcomes. Let's dive right into it.
Our understanding of hemodynamic consequences of cardiac pacing has evolved dramatically over past decades. Dual chamber pacing, rate responsive pacing, rate adaptive pacing, and differential AV intervals, alternative site pacing, ventricular pacing avoidance algorithms, ventricle rate regularization, and cardiac resynchronization therapy are all attempts to mimic or restore normal cardiac conduction and physiology. Applications of the appropriate pacing therapy first requires understanding of normal physiology, the various interrelated components contributing to the normally functioning cardiovascular system, and the effect of cardiac and non-cardiac disease of these individual components, as well as the function of whole. Given that our understanding of cardiac function in normal and abnormal condition is incomplete and that current technology is imperfect, the goal to mimic perfectly the normal cardiovascular system under all conditions has yet to be made. Nevertheless, hemodynamic pacing continue to attract intense interest as technological advances bring us closer to that goal. Challenges to cardiovascular system such as exercise or emotion usually results in an increase in cardiac output, which is determined by heart rate and stroke volume. The cardiovascular demands incurred with exercise are usually met primarily by an increase in heart rate and secondarily by increase in stroke volume. Aerobically trained athletes can increase stroke volume proportionately more, thus enabling them to reach the same cardiac output with smaller increase in heart rate. Abnormal physiology. A large segment of pacing population has cardiac disease or other comorbidities that affect cardiac performance. These conditions can be characterized as those affecting heart rate, those affecting stroke volume, and those affecting both. Chronotropic incompetence means an inadequate heart rate increase with exercise or stress, may be due to isolated sinus node dysfunction, autonomic dysfunction, or drugs. Individual with normal LV function may be asymptomatic at rest but experience the symptoms with activity depending on activity level or comorbid conditions such as pulmonary disease and the severity of chronotropic incompetence. Patient with a significant LV dysfunction may be less tolerant of chronotropic incompetence because their impaired stroke volume makes them more dependent on heart rate to maintain the cardiac output. These patients may be unaware of how symptomatic they are unless objectively evaluated. Myocardial contractility may be impaired by coronary artery disease, myocardial infarction, non-ischemic cardiomyopathy, valvular disease, or pericardial disease. The basics of hemodynamic pacing. Appropriate heart rate response during exercise, that is chronotropic competence, is the most important contributor to cardiac output, especially at moderate or extreme degree of exercise. At rest and at low level of activity, AV synchrony contributes significantly to achieving an appropriate cardiac output. You can see that in the schematic representation of the contribution of atrioventricular synchrony and rate response to cardiac output at various level of activity. At rest and low level of activity, maintenance of AV synchrony makes a proportionately greater contribution to cardiac output. At higher exercise level, heart rate clearly contribute more to cardiac output. AV synchrony is perhaps just as important as rate response for achieving optimal cardiovascular and hemodynamics in typical patients. Restoration of both rate responsive and AV synchrony should be the goal of physiological pacing, and it should be viewed as complementary. Let's say about AV dissociation and VA conduction. The earliest indication for pacing was complete heart block, and ventricle only pacing was the only available mode. Establishing a stable ventricular rhythm was life-saving and overshadowed the fact that normal cardiac function was not re-established. However, some patients experienced hemodynamic decline with this mode of pacing. Later, it was established that hemodynamic impairment could be caused by VA conduction and atrial contraction against a closed AV valve, which could result in pacemaker syndrome. Pacemaker syndrome may be manifested by a variety of symptoms and physical signs. Pacemaker syndrome was initially identified as a complication of ventricle single chamber VVI pacing. However, it may occur with any mode of pacing when there is AV dissociation. It may also occur in person with markedly prolonged AV delay, with atrial systole effectively occurring concurrently with or after ventricular systole. You can see in this diagram, the diagram A shows the optimal cardiac filling with atrioventricular synchrony. The image B shows the ventricle is not optimally filled and there is a contraction against a closed AV valve, which is due to the ventricular pacing. And the picture C shows the consequences of the effect happens from the diagram B. This results in loss of AV synchrony and the venous pressure is increased. You can see the backflow and the multiple symptoms may occur. The potential symptoms of pacemaker syndrome includes weakness, chest pain, syncope or near syncope, dyspnea, cough, neck pulsation, apprehension and abdominal pulsation. The major physical findings of pacemaker syndrome includes hypotension, congestive heart failure, Kennan A waves, blood pressure decline during ventricular pacing, decrease in cardiac output and arterial pressure, increase in peripheral vascular resistance during monitoring. Pacemaker syndrome can often be prevented by simple hemodynamic evaluation at the time of pacer implant. Pacemaker syndrome is likely to result from VVI pacing if the blood pressure drops by more than 20 mm mercury during ventricular pacing. Retrograde conduction is not uncommon even in patients with complete heart block. If hypotension develops, implantation of dual chamber pacing system is requisite because retrograde conduction may be intermittent. Absence of hypotension at implant does not preclude pacemaker syndrome. The management of patient with VVI pacemaker syndrome after VVI pacemaker implantation include upgradation to dual chamber pacing system, along with reducing the lower pacing rate to encourage conduction of sinus rhythm. Advantages of AV synchrony. Systemic blood pressure and cardiac output have been the subject of much of the discussion regarding the importance of maintaining AV synchrony. For grouped patient data, AV synchrony generally provides similar or slightly greater systolic and mean blood pressure than ventricular pacing. Another advantage of AV synchrony is cardiac output. Cardiac output, more than any other hemodynamic feature, has been the focus of discussion and investigation relating to AV synchrony. Properly timed atrial contraction provide a significant increase in ventricular end diastolic volume and is responsible for the so-called atrial kick. Studies have shown a wide range in the actual importance of atrial contribution to ventricle filling depending on the patient population and study condition. By increasing the end diastolic volume, both right and left ventricles, the cardiac output is in turn increased. The average increase in cardiac output in a broad-based pacing population, if AV synchrony is maintained, appears to be between 15 and 25% in comparison to non-AV synchronized pacing. The next important benefit is atrial pacing maintenance, atrial pressure maintenance. Cardiac output and blood pressure have been the primary foci of most discussion about the importance of AV synchrony. And the most extreme cases of intolerance to ventricle pacing related to these factors. However, that an increase in atrial pressure during ventricle pacing is the most common mechanism by which symptoms are produced when AV synchrony is not maintained. During AV synchrony, atrial contraction augments ventricle end diastolic filling pressure while maintaining a low mean atrial pressure throughout the diastole. In the absence of AV synchrony, a high mean atrial pressure is required to achieve the same degree of ventricle filling. By this mechanism, AV synchrony is associated with low venous pressure and left atrial pressure. You can see in this femoral artery pressure recordings from one patient shows a typical example of blood pressure comparison among atrial, atrioventricular and ventricular pacing. The first diagram is taken from atrial pacing, the second one is from AV sequential pacing and third one is from ventricular pacing. In this case, essentially no difference exists between the blood pressure when comparing atrial to atrioventricular pacing, but the blood pressure during ventricular pacing is slightly lower during either atrial or atrioventricular pacing. The recording shows pulmonary capillary wedge pressure recording from a single patient during AV pacing on your left and ventricular pacing on your right at 80 beats per minute with the AV interval of 150 milliseconds. The right panel shows pulmonary capillary wedge pressure during ventricular pacing at 80 beats per minute with intact VA conduction. A relatively normal pulmonary capillary wedge pressure tracing is produced during AV sequential pacing with mean pressure between 4 and 8 mm mercury and without significant phasic, phasic aberration. In contrast, during ventricular pacing, one can see that the mean pressure are elevated to between 8 and 12 millimeter mercury with a large A waves that are times exceeding more than 16 millimeter mercury. This elevation in atrial blood pressure and specifically the production of giant or cannon A waves occur because of left atrial contraction against a closed mitral valve. The increased pressure wave is present not only in the left atrium but also in the pulmonary veins and pulmonary capillary wedge position. The same phenomenon occur on the right side of the heart as well.
That wraps up part 1 of this topic in Cardiac Pacemakers, a beginner's guide. Link to part 2 of this lecture is in the description. Head over there to continue your learning journey. And when you're ready to test your understanding, visit our website to access two powerful assessment tools: a comprehensive knowledge assessment featuring over 500 MCQs based on the entire video series. An IBHRE style exam simulation consists of 5 blocks, 40 questions on each block, timed to help you sharpen your time management for the real exam. These assessments are ideal for board exam candidates and healthcare professionals alike, whether you're aiming for IBHRE, CCI, EHRA, or just want to solidify your rhythm management expertise. Check the description for all links and start challenging yourself today. If you're enjoying this series, like, share, and subscribe to Medfoxes. It really helps us grow and reach more learners. Thanks for watching, and I'll see you in the next one.